Good afternoon, distinguishing faculties, the residents, colleagues. So today my topic is recent advances in diagnostics of tuberculosis. Before going to that, I would like to give some information regarding our institute's contribution and performance in care of for conducting NTP. So we have a distinguished unit of evaluation for mycobacterium tuberculosis test in our hospital. So mechanism of flow to this unit is from OPD and IPD through central lab, then this microscopic and NAT evaluation and clinical evaluation and further IPD evaluation and coming to a conclusion or diagnosis of tuberculosis patients. And further we differentiate them in drug sensitive and drug resistant tuberculosis cases. So further they will be registered in our different tuberculosis registers and further notified to the government website and will be distributed medicines accordingly, or they will be referred to the higher centers as taluka place or district level or state level or national level. So NTP treatment center is well established in our hospital and institute with due counseling and referral and then notification and real-time initial entry. And this all will be taken care with the help of medical officers, then lab technicians, then TB health volunteers and supporting senior laboratory supervisors. So further giving a brief review about our unit, this is a mycobacteriology unit with TB NAT or True NAT analyzer and extractor machines. Nothing, not going in details. This is the internal quality control of the True NAT machine, which is with us in our hospital. We can visit the unit in central lab. These are the test results like detected, not detected, then resistance detected, resistance not detected, indeterminate, invalid, no results, error. This all should be notified and submitted as a monthly register to the government centers as well as a real-time entry in web portal. So we have, since our this NAT unit detected so many tuberculosis cases, and this is the summary in year 2024. Total treatment of patients has been done about 98, pulmonary tuberculosis 39, extrapulmonary 57. In 2025, 114 cases, 59 pulmonary and 57 extrapulmonary cases. So this is our overall statistics till today, since we have a NAT machine. So coming to our today's TB 26, yes, we can end TB led by countries, powered by people, but now we are here to led by Dr. B.K. Patil and powered by B.K. Patil and as well as District Tuberculosis Center. So this is since 1882 to 2020. How is the journey so far in diagnosis of the tuberculosis mycobacteria? So TB diagnostic laboratory methods have been huge revolutionary changes since last 2 decades, we can say almost. What is new in tuberculosis since last 2016-17 to 2020? There is a huge difference and paradigm shift, you can say, in the diagnosis of the tuberculosis bacilli, and we can within hours can have a diagnosis of infection as well as disease in the patient. Nonetheless, we should have a proper history, clinical examination. This role cannot be taken out from any investigation. So, coming to the previous slide, you can see the various quarters of the each year since 2017. So we can have various line probe assays, the liquid culture media and NAT. So not going in details about the each. Going to the next slide is gene expert, MTB, repurposing resistance and XDR machine, then proven at MTB, MTB plus, MTB repurposing resistance, then loop mediated isothermal amplification test. This will again contain a liquid culture media and next generation sequencing or whole genome sequencing. So microscopically, it is recommended for all TB level laboratories in peripheral and higher levels. So LED microscopes or fluorescence microscopy, again it has its own importance. Conventional bright field microscopy can be done safely with minimal biosafety precautions required to monitor responses to anti-TB therapy. So global crisis, already all distinguished faculties given a lot of information regarding. Coming to a particular points, more than 4 lakh MDR TB or repurposing resistance TB cases in last 2 years. Only 44% of MDR TB patients are on treatment. XDR TB treatment success rate is less than 40%, and 80% of repurposing resistant TB is also INS resistance. So possibility of other drug resistance, maybe first line or second line, is always may be there, or maybe in patients who have not received any AKT or anti-tubercular treatment. So 8.2 million cases are newly diagnosed, out of which 26% are from India. So each undetected case infects 10 to 15 people per year, and average delay in diagnosis is 2 to 3 months in India. So we have to delay the diagnosis time. So what is the key in end of TB today is the early diagnosis. So COVID-19 disrupted the TB detection by 18%, and only early diagnosis breaks the transmission chain. So coming to the strategy and targets, renamed from RNTCP to NTP in 2020. Then strategic plan up to 25 from 17 to detect, treat, prevent, build. India target was up to 25, but now with WHO it is 2030. So TB incidence is decreased by 70% till today. NBPAL, the regimen, 80% success rate in 6 months. This is for XDR and other resistant TB cases. So NBPAL is, M is for moxifloxacin, bedaquiline, then pretomate. Then diagnostic pillars under NTP, 4,000 plus in expert machines installed pan-India, 80 labs with liquid culture, 60 first line assay or liquid culture drug sensitivity test, and 49 second line. 74 labs with LTA, 61 certified for second line probation. TrueNet deployed at district and sub-district level. Niche portal real-time national surveillance. So coming to the general scenario, tuberculosis remains a major public health problem in developing countries like in Asia, Africa. India is due to undue diagnostic delay in diagnosis and hence treatment of TB is the one of the developing country which is having the major junk in the global statistics. While diagnosis of TB entered into an era of molecular detection of tubercle bacilli, which is faster and rapid, we are sticking to the sputum examination till 2 decades before on microscopically diagnosing TB, which is comparatively less sensitive. Sensitivity and specificity of each test of diagnosis of tuberculosis matters for preventing or disrupting the chain of transmission of disease. So WHO has recommended the molecular assays like Gene Expert, MTB, repurposing resistance, Gene Expert Ultra, as well as TrueNet, the initial test in diagnosis of tuberculosis and repurposing resistance. So this has made a paradigm shift in the end of TB program. So conventional diagnosis where we started was sputum smear microscopy, solid culture like LJ medium, Lawrence Johnson medium, liquid culture like MACDATE, MGIT, microbacterial growth tubes with liquid culture media, conventional chest X-ray, and tuberculin skin test. With nowadays we have a CYTT evaluation also with ESAT 6 and CFP10. So coming to the next slide, which is related to the AI powered radiology and computer aided diagnosis. That is what we are at now, where we are using the AI tools to diagnose the tuberculosis and differentiating between the different infected conditions and malignancy and others. AI and this radiological CAD evaluation has a limited role in elderly individuals above 60, but still it is given major importance in today's life. So all 5 algorithms related to the AI is CAD4 TB, depth imaging from the Netherlands, high sensitivity, low cost deployment, then QXR from Pure AI, Indian, deep learning, X-ray plus CT plus ultrasound evaluation, then unit inside CXR, unit South Korea, parenchymal lesion detection, then infrared DR, InfoVision from China integrates with PAC system, which we're using in imaging with CT scans and all. Then JF CXR1, JF Healthcare China, multi-disease detection. So these have reduced the expert tests by 50% while maintaining the sensitivity more than 90%. So in Pure AI, India spotlight deep learning, X-ray, CT, ultrasound deployed in NTEP's 81 mobile diagnostic vans. Enables faster triage in rural areas with high burden of tuberculosis. The WHO recommended it in 2021 for adult TB screening. So what is 18F FTG PET CT? It is also helpful in evaluating the active lesions. So non-invasive treatment monitoring FDG accumulates in the TB lesion inflammatory cells. Predicts treatment outcome in usually drug-resistant cases, MDR and STR TB. PET glycolytic activity decrease with effective treatment. So we can very well judge the treatment effectivity in drug-resistant cases. So molecular tools in TB diagnosis, the revolution. Starting from the 1953, you can see the DNA model by Watson and Crick. Next, coming to the PCR invention by Carey Muffin. Then PCR applied to TB diagnosis in 1990s. Then in 2000, real-time PCR with MPCR. And in 2010, it is a gene expert WHO endorsed. And in 2016, LAMP. Then NGS, next generation sequencing. CRISPR and TrueNAT. We'll come to that. Conventional PCR turnaround time is 4 to 6 hours. Real-time PCR 2 to 4. Gene expert 2 hours with MTP and recombination resistance. Then with XTR also 2 hours. TrueNAT MTP around 1 hour. LAMP is 1 hour and genome sequences may take days. But sensitivity, if you see, the TrueNAT MTP Plus gives 91% sensitivity. So, Gene Expert MTP and TrueNAT is having its own importance. Gene Expert platform is the game changer for the TB diagnosis. So, Expert MTP RIF is cartridge-based NAT, which we are using, sampled to answer in 2 hours. Maybe less than that, 1 hour and 45 minutes. 88% sensitivity with 98% specificity. The recombination resistant detection proxy for MDR-TB. India rollout 2013 under RNTCP and NTEP. 4,000 plus system installed across India. But it has a low sensitivity in EPTB, that is extrapulmonary tuberculosis. So pleural fluid 30% and CSF 50%. So definitely it has a less sensitivity. Pediatric TB sensitivity is only 11%. So we have a Gene Expert MTB-RIF Ultra. Detection limit is 16 colony forming units versus 13 colony forming units which was original. Pooled sensitivity is 91% and specificity is 95%. So better performance and in possibly with Ultra, Gene Ultra. Improved EPTB and HIV TB detection. Both WHO endorsed recommended alongside RIF. Preferred test for CSF in TB meningitis. Slightly higher false positive rates. So coming to the Gene Expert MDR and XDR. Detects rifampicin, INH, loans, amikacin, kanamycin, capreomycin, and ethanamide, all in a single 90-minute test run. So it is definitely useful for patients who are sputum positive and drug resistant tuberculosis. So sensitivity is 94 to 100% versus sequencing. Ionized resistance sensitivity is 94 to 98% specificity. Fluoroquinolones 93 compared to 98% specificity. And WHO endorsed its scaling under NTP. So coming to the India's indigenous molecular diagnostic platform, that is TrueNat MTB, detects MTB complex first line initial detection test. TrueNat MTB plus higher sensitivity, 91% versus Gene Expert, better for HIV TB co-infection. TrueNat MTB rifampicin diagnosis, the reflex test for rifampicin resistance run only on MTB positive samples. So parameters compared to TrueNat MTB plus and Gene Expert MTB with rifampicin resistance, MTB plus TrueNat is battery powered and Gene Expert MTB rifampicin is needs electricity. So what are the key advantages? And NTP deployment. Battery operated works without stable electricity, portable, which we are having, usable at peripheral labs. WHO recommended since 2020 as an initial TB diagnostic test. You can simultaneously go for microscopy, but you can get results earlier with this. So HIV TB co-infection can be very well evaluated. The manufacturer is Mol Bio from Goa. So coming to the next newer additional evaluation which is required once we go for Gene Expert TB Ultra and all detecting the rifampicin resistance. We need to know the other drugs, first line or second line drug resistance also. So line probe assay, first TB NAT endorsed by WHO in 2008, reverse hybridization big technology. First line probe assay detects INH and rifampicin resistance, RPO-B, CAT-G and INH agents. Second line MTB drug version 2.0, fluoroquinolones and XDR-TB detection. In India, 74 first line probe labs and 61 second line probe subdivided labs. So from here, if there are drug resistant tuberculosis patients we are having, then we have to refer it to the further centers. So limitations or novel mutations are not covered by these probes. What is LAMP and next generation sequencing? Loop mediated isothermal amplification. So WHO endorsed TB LAMP since 2016. Sensitivity is 79%, specificity compromised. But open tube format lab is required, not for peripheral use. Next generation sequencing and whole genome sequencing detects all known and novel resistance mutations. Direct clinical sample sequencing, no culture is needed. So limitation is the cost, then bioinformatic expertise and centralized labs. Coming to the CRISPR, that is clustered regularly interspace short palindromic repeats. It is further like Sherlock and Dieter's based diagnostic emerging frontier since 2025. So Cas13 and Cas12 genes are detected, integrates with the lateral flow strips for the field deploying point of care format. So currently research phase promising for India high burden peripheral setting may give a good or promising results in future, likely to have our ANCP in 2030. So immunological tests for latent TB where there is an infection but no disease. The tuberculin skin test is a simple, cheap, limited BCG cross reactivity common in India. So this is the limitation. Then quantiferon, TB gold and T-spot, IGRA based interferon gamma release assay, better specificity than tuberculin skin test with PPD. Preferred in immunocompromised patients. CYTB skin test, recombinant ESAT 6, that is early secreted antigen, and cell protein 10 phase 3 validation, not BCG cross reactive. CYTB is having important that it will not have any effect of disease on determination. So coming to the expert MTB host response, the finger stick blood-based no sputum is needed, measures mRNA of 3 host genes, TB score, sensitivity is 87%, specificity is 94%, HIV agonist, then all 90% sensitivity specificity drops to 86%. Children and HIV sensitivity only 41%. Currently, prototype stage, more data is needed. What is next for the flow through or lateral flow in Bhopal novel antigens? So we can have 3 novel antigen SS. The name is from Sarman Singh, this scientist, SS1, 3 and 5 from Singh land. No equipment, no electricity or skilled staff is required. Field deployable for community screening by ASHAs, detect pulmonary TB and EPTB with promising sensitivity, proposed as a trials tool combined with confirmatory gene expert, Singh et al., respiratory from 2017. What is next? That is Fujifilm assay, urine-based lipoaraminomannan detection. It is specifically useful in immunocompromised patients with HIV. We can detect tuberculosis infection with urine examination and MTB cell wall component in urine. The best sensitivity in HIV patients with low CD4 count. Lancet Global Health 2023 validated in 4 African countries. No equipment or electricity is required. Potential role in India's HIV TB co-infected patients, also given in Lancet Global Health. So, NTP diagnostic cascade and proposed algorithm. First is community screening with symptom screening plus AI CAD CXR. This is proposed algorithm. So first will be the community screening, symptom screening plus AI CAD CXR, pure AI or NTP bands. Second will be triage at point of care test, lateral flow, Fujifilm, rollout TB. Third will be the rapid molecular diagnosis with Gene Expert Ultra, TrueNat MTB plus rifampicin resistance. Fourth will be drug sensitivity test with drug resistance profiling, Gene Expert XDR line to message, first line, second line drugs, and MDR XDR. And last will be treatment monitoring with culture and MGIT, drug sensitivity, and PET CTs or next genome sequencing will be with central labs. So NTP diagnostic infrastructure in 2024 says 4,000 Gene Expert system with 81 mobile TB diagnostic vans and 80 liquid culture labs, 74 line probe assay labs, and Nikshay portal that is for real-time surveillance. So, what are the challenges today? What are the gaps and future directions? Current challenges are 1/3 of the global TB cases remain undetected annually. Low sensitivity in extrapulmonary tuberculosis cases and pediatric and HIV TB co-infection. So Gene Expert poor in possible disease. Next genome sequencing and advanced platforms are not scalable to the peripheral labs. AI-led tools unreliable in children and elderly, as we have discussed before. Novel resistance mutations not covered by current LPAs. Declining global TB funding post-COVID. COVID has made a lot of difficulties in our NTB 2025. We are quite behind our goal due to COVID insurgence. Declining global TB funding, stigma and healthcare access barriers in rural India. Serological tests, sensitivity and specificity is inadequate. No validated non-sputum point of care test for mass deployment. So what are the future directions? CRISPR-Cas-based ultra-sensitive point of care diagnosis. Next is breathomics and volatile organic compound biomarker. Whole blood and urine gene expression signatures like RISC and IP10. AI integration for multi-omic TB diagnostics. Nano diagnostic quantum dots, nano biosensors, nanoparticle probes. Expanded TrueNet platform for more drug-resistant targets. Portable genome sequencing. or generation sequencing. Oxford Nanopare Minion for field use. Pediatric care algorithms. ICMR DBT collaboration. M health tools linked to niche for adolescent monitoring. Biomarker discovery panels. Proteomics and metabolomics. So what is the comprehensive diagnostic algorithm after this all presumptive TB, T population, all TB patients, non-responders, NAT has diagnosed with help of microscopy, chest X-ray, the first specimen at the NAT site. First is like recombination resistance and without recombination resistance. If the resistance is not detected, go for first line probe assay, drug sensitive TB regimen, then go for if if resistance is detected, go for drug sensitive regimen. If no, and if yes, then go for stop drug sensitive TB regimen. Go according to the resistance data. Then H mono, that is INH mono and poly drug resistant tuberculosis regimen. Then you will go for reflex testing for the second line probe assays, then liquid culture, drug sensitive test with second line other group A, B, C drugs and additional resistance intolerance, non-availability of the drug or further discordance or problems in detection and management of the tuberculosis patients. And you have to modify the regimen for the drug resistant tuberculosis cases. And then further you have to re-evaluate non-responders also. So coming to the recombination resistance detected, first line probe assay, second line probe assay, after completing pre-treatment evaluation, check for the niche and culture and drug sensitivity lab if line probe assay is available. Go for the additional resistance detection. If resistance is detected, then go for the CAT-G and INHA mutation detection. If not, and quinolones resistance not detected, go for the shorter oral beta cleaning and regimen. And if S, then you can go for the longer regimen for MDR and HDR regimens. And you have to do other exclusion criteria for the shorter regimens and go on till the surveillance of these drug resistant tuberculosis patients, surveillance and for the cure. So this is again the same drug resistant tuberculosis diagnostic algorithm we have discussed as well as Dr. Kund has nicely discussed before. Coming to the conclusions, so as I said prior, the curtailing the time delay in diagnosis is the key to end the tuberculosis program. So TB diagnosis has transferred from the AFB smear to the AI integrated molecular platforms in just few decades. So Gene Expert MTB, Recombination Ultra and TrueNat are now the cornerstones of the Indian NDEP accessible, rapid and accurate program. So drug resistant TB demands Gene Expert HDR, second line probe assay, next generation sequencing for comprehensive resistance profiling. India's contribution to TrueNat, QueerAI, novel antigen based point of care tests, global are globally significant. A non-sputum point of care trials test combined with confirmatory molecular test is ideal model for the India with high burden incidence of the cases. NDB 2025 goals require sustained investment, digital health scale, niche and community engagement. Elimination by 2030, India 2025 is achievable with comprehensive detect, treat, prevent and build strategy. Thank you. Question?
Thank you so much, sir.